I would like to introduce Dr. Tournay, and she's pediatric neurologist in the College of Medicine, University of California, Irvine in Orange, in USA. And she's working in the adult Down syndrome program there. And she will explain us also the relationship between Alzheimer's disease and other health issues in Down syndrome.
So what I'd like to talk about a little today is a little bit about the clinical and clinical research aspects of Down syndrome and Alzheimer's disease. I tried to go over a little bit about the strengths and challenges. One strength is that there's been an increasing number of studies funded both by the NIH in the US and pharmaceutical companies on both Alzheimer's disease and in Down syndrome, and looking at Down syndrome and cognitive enhancements in children. There's also an increasing awareness of the issue of Alzheimer's disease as people with Down syndrome are aging. And there's several centres opened in the US with specialised clinics for care of adults and children with Down syndrome. But there's still a lot that we don't understand and that poses great challenges. One issue that is very heartbreaking for parents and people that love those with Down syndrome is that apart from Alzheimer's disease, people with Down syndrome can regress or have significant psychiatric issues, and we often don't understand why that happens. Not uncommonly in childhood, children with Down syndrome will have regression that looks very similar to an autistic regression, but occurs much later than you'd see the onset of autism in a child without Down syndrome. It often occurs at around the age of around 10, and we don't understand why that happens. And very frequently the children don't return to their usual, to their pre-morbid state. Often in their 20s, people with Down syndrome will really regress and revert into themselves and become very withdrawn. It may be psychiatric, it may be something else that's going on, and we don't understand what it is or really how effectively to treat it at the moment. The other issues are a collection of specimens, brain and other specimens for research, participant recruitment. One of the issues in doing research with people with Down syndrome is that there's a wide range of functioning at baseline. Another issue is that when we're seeing adults with Down syndrome, it's often difficult to to know at first whether they do have Alzheimer's disease, whether they're in the very early stages of Alzheimer's disease. And so we often see them back in a few months and see if there's been any interval changes to confirm the diagnosis. There's no good clinical staging criteria for Alzheimer's disease in Down syndrome, and it's not the same as Alzheimer's disease in the non-Down syndrome population. I'll explain that a little bit later. Comorbid medical conditions. The onset of seizures is very common in people with Down syndrome and Alzheimer's disease. And often you get a significant decline in their level of function when you get the onset of seizures. Behavioural issues can be very, very challenging to family members and caregivers. Sensory impairments are common and can produce challenges for conducting research. And then there's the issue of consent. Who is the appropriate person to provide consent for research? There's a need for psychological measures that can try to estimate the level of function throughout the population with Down syndrome. Is it really realistic? Are you going to be able to come up with a measure that will assess functioning in very high functioning people and look at what happens if you provide cognitive enhancement? There's a need for clinical staging in Down syndrome and Alzheimer's disease. And then one challenge that we're constantly faced with is the reliability of the informant that we get the history from. Expectations. I think the thing that we'd all be really aiming for is to try to prevent or postpone the onset of Alzheimer's disease and Down syndrome, or at a minimum slow down the rate of decline, and to improve diagnostic classification to improve the quality of clinical trials. This is John Langdon Down, who had Down syndrome. He lived at around the early 1900s, and he was the grandson of John Langdon Down, who described the clinical features of Down syndrome. Sadly, the two never met. John Langdon Down died before his little grandson was born, which I think is a shame, because I think they'd have had fun together. So just a little bit about the clinical aspects of Down syndrome. It's the most frequent form of cognitive impairment caused by a chromosomal abnormality. And of people with cognitive impairment with developmental disabilities, about 10% of them will have Down syndrome. In the US, there's about 5,000 children born each year with Down syndrome. It's been estimated that there's probably about 300,000 individuals with Down syndrome in the US. A lot of pregnancies with Down syndrome are spontaneously aborted before the baby comes to term. And as you know, it's caused by a triplicate state of all or part of chromosome 21. Life expectancy is significantly increased in the past 100 years for people with Down syndrome. It was essentially a death sentence in childhood in the early 1900s. The life expectancy today is into the mid-50s. But the thing that is taking the lives of adults with Down syndrome is Alzheimer's disease. Interestingly, John Langdon Down was very familiar with cognitive decline and dementia in adults with Down syndrome. This is one of his friends back in Victorian times. He set up a private hospital called Normansfield on the outskirts of London, which is now the headquarters of the Down Syndrome Association of the UK. And I visited there 2 or 3 years ago and found it very moving. He knew Down syndrome. He knew what they enjoyed. There was a theatre there. There were theatre productions once a week that were apparently very much enjoyed. And what I found particularly moving is that there's some letters there from one of the gentlemen with Down syndrome called Walter Ridpath. And Walter sounds as if he was quite a cheeky little character. He would write little letters, little wish lists to John Langdon Down before he went into London, of little shopping lists that he'd like things brought back. And he got fairly expensive tastes. Walter would like a couple of rings, silver rings, and a new picture. Premature aging affects some but not all of the organ systems in Down syndrome. You're familiar with Alzheimer's disease. The other sorts of things that are significant issues are sensory impairments. Cataracts form at a much earlier age in adults with Down syndrome than in the non-Down syndrome population. Hearing impairments common. And then just the physical appearance, skin laxity and wrinkling, alopecia and greying of the hair, early onset of menopause, osteoporosis, which can be a significant issue because our folks with Down syndrome tend not to complain. We've had people walking around on a fractured pelvis and not saying anything about it. Their caregivers started having concerns because they were wobbling when they were standing up. Dental health is also an issue. Tooth loss and gingivitis is common. But there's also things that you tend not to see in adults with Down syndrome that are much less common than in the non-Down syndrome population. They tend not to get hypertension or coronary artery disease. Stroke due to atherosclerosis is uncommon. You don't tend to see vascular dementia and several mental health issues and many solid tumours. The ones that you do need to watch out for are testicular cancer, which is more common. But the solid tumours that kill the rest of us, like breast, colon, prostate, you tend not to see those. As other people have mentioned, you tend to get the neuropathological hallmarks of Alzheimer's disease in Down syndrome at least by age 40, and probably very much earlier in life. Clinically, Alzheimer's disease causes a lot of health problems. falls, malnutrition, incontinence. Epilepsy is very common in adults with Down syndrome and Alzheimer's disease, in contrast to Alzheimer's disease in the non-Down syndrome population. Depression and mood disorders are also common, and the usual cause of death is pneumonia. To give you an idea of the incidence, about 20% of individuals with Down syndrome over the age of 40 will have Alzheimer's disease, and it increases as they age. It's not a prerequisite to having Down syndrome, though. We have 1 or 2 adults in their 70s that are non-demented. So by no means is it all people with Down syndrome that will develop Alzheimer's disease, but sadly it's the majority. And there's a number of genes that may be related to the pathology and the incidence. The other thing, the difference between Down syndrome and Alzheimer's disease in the non-Down syndrome population is that it's much more rapidly progressive in general. I think our most rapidly progressing patient went from first symptoms to death in about 18 months to 2 years. Typically, it's about 5.5 years. We've had a few that have lived more like 10 years. One question that we get asked quite a bit is, how do you tell that someone is developing a dementia if they're already developmentally disabled? The caregivers are very important. The caregivers at the work centre, family members and group homes. If you get a good history, you can start putting the picture together. And the sort of things that you might hear is that people are needing more prompts to do the activities that they've previously managed without difficulty. They can have loss of memory or confusion. They may have difficulty finding their way around their day program. They often withdraw from social activities. They'll go and spend time in their room rather than interacting with the rest of the family. They may have changes in sleep pattern or changes in their eating. They may lose weight. And they may become agitated. It's sometimes described as aggression, but I think it's more frustration, not understanding the demands that are made of them. So having difficulty getting themselves ready to go to their day program, and then they may lash out at mum or dad because they're getting frustrated and hurried along. They may have the onset of seizures. They may either be big convulsive seizures or myoclonus, which myo means muscle and clonus means jerk, so it's more of a jerky movement. One thing that's very common is difficulty in walking, much more hesitancy when they come to curbs or steps, and even transitions in flooring, just going from a dark surface to a light surface, they'll take a big exaggerated step over it, and they may have incontinence. The assessment needs to be very individual specific. So if you've got someone who was at a relatively low level of functioning, it might be a little bit more difficult to confirm the diagnosis of Alzheimer's disease than in someone that's higher functioning, and you can see a more dramatic drop-off in their abilities. So it's important to establish a baseline. One thing that we tend to do is that we see our adults with Down syndrome probably about once a year and can map them over time so that we get an idea of if they're developing symptoms. It's really important to make sure there's no underlying medical condition that's reversible. Quite a number of our adults have been diagnosed with Alzheimer's disease, and when we see them, it becomes apparent that there's another medical issue. They've got uncorrected hypothyroidism, they've got undiagnosed celiac disease. They may be on a ton of psychotropic medications, and once you back off on those, lo and behold, their level of function improves again. They may not be able to hear, they may need new hearing aids, or they may be depressed, particularly if one of their loved ones has died. So how do you make the diagnosis? You get a good history, preferably from several people, so that you're getting a different slant. You talk to family members or caregivers at the group home and at their day program. Physical and neurological exam. There's a number of different assessment scales. The one that we tend to use is one from the Netherlands, the Dementia Questionnaire for Mentally Retarded Persons, which gives a rating for social and cognitive behaviour, and you can map that over time. Sometimes we do brain imaging, not necessarily, and then clinical labs to exclude any underlying medical issue. This is some drawings from one of our friends that we followed over the course of her dementia. The first diagram, she was already demented. She was very keen on colouring, and then you'll see each of these is 6 months apart, and just progressively how they become simpler as her dementia progressed. Oh, thank you. I'm just going to quickly outline how Alzheimer's disease and dementia presents. This is a young man called Mark, whose family gave us permission to talk about him. He functioned in the mild to moderate range. He was a Special Olympics champion, had lots of interests and hobbies, was quite independent. But when he was about in his mid-40s, his family and people that knew him noticed that he was starting to have problems. Tasks took longer to complete. He was having trouble at his workshop, developed difficulty walking and a fear of water. Often bathing is a big issue for people with Alzheimer's disease and Down syndrome. He was started on donepezil to try to improve matters and had some limited improvement. But 6 months later, it was obvious that he was continuing to decline. His speech had deteriorated. He became incontinent. He had an MRI of his brain. It showed moderate atrophy. And he continued to decline quite rapidly after that. Developed the epilepsy and increasing difficulty with gait, became unable to walk. His family made the decision to stop the donepezil. They didn't want to have him maintained in that sort of state. They wanted to allow the disease to progress. His care became increasingly demanding on his family, who was elderly. He was hospitalized. A gastrostomy tube was placed. He was transferred to a skilled nursing facility. Sometimes... Eric Doran and I spent significant time talking with our families about what to expect during the course of disease. Different families make different decisions as regards end-of-life care. Mark's family opted for quite aggressive care, but unfortunately his disease continued to progress, and he died in his, at the age of 46. And his family generously donated his brain. Mum asked a little while after he died what had happened to his brain, and Eric was able to tell her that samples had been sent to several centres in the US and to countries overseas. And she said that Mark always did like to travel. So it gave her some comfort. And I think this is the essence of why it's so sad, what we're seeing in adults with Down syndrome developing Alzheimer's disease. Mark's in the middle. You can just see that the light has gone from his eyes. And these are people that love him. This is his girlfriend of 25 years and his friend that has been his best friend for about the same length of time. And it's heartbreaking because a lot of the people that we're seeing with Down syndrome and Alzheimer's disease, they've got elderly parents. It's very challenging for them to care for their loved ones at home now. And these are the parents that have brought up their children with nothing. It was before they had resources to provide early intervention, and it's heartbreakingly sad for parents to just see their children lose all that they've gained over the years. It's very, very sad. Challenges for the future, just clinical classification of participants in clinical trials can be difficult. We need better neuropsychological and cognitive assessment tools and outcome measures. The issues of recruitment can be challenging, and we need help from the community of people with Down syndrome as well.
Down Syndrome Association, not a UK organisation.
Oh, sorry.
No, it's okay. My colleagues in Scotland and the First Minister up there would be very concerned that I raised the issue that Scotland is separate from the rest of the UK.
Oh, thank you. Thank you.
But just to add, your photos and your stories about Normansfield, if people are interested, the DSA has produced a tremendous publication called Tales from Normansfield, which if you contact them, you can get, which talks about John Langdon Down and the theatre and the kinds of productions. And I think when I went there and when I read the book, the learning point is that John Langdon Down had a really high expectation of the people who lived in the residential hospital, and they all learnt to play a musical instrument. They all did a job. And I think, you know, that's one of the problems we have with society now, is we don't have those expectations.
Yeah, it was way before his time.
And I had a question for you, a very brief one, maybe not brief. What is troubling to me is that we have young adults before the age of 30 that are showing these changes in behavior. And we don't really know what's going on, do we?
No, we don't. And I don't think I've seen any of them that have come back from the regression that they've had. And it's very, very sad. But we don't know what's happening.
It's not Alzheimer's disease. No. It's something else.
It's something else.
Right. Has anyone in the audience had this experience?
I'm Shen Smallwood. I'm from a support group down in Sussex. And yeah, just to make a comment about that, I know two parents, both had said the same thing to me. Both have got very, very young children. One child was about 6 when they started having that regression, and then another child of 8. And again, you know, there's just no, you know, okay, well, where do we go from here? You know, and just as young as that. So, yeah, it's a big deal.
I think this makes the point that special clinics for adolescents and young adults with Down syndrome are very important, because if you rarely see this, you're going to say, well, it's just mystery. But if in fact you start to see a pattern, it might make you more aware of it and more willing to explore it.
Thanks, Bill. I just want to advance a hypothesis about that, and drawing in some of the information that we've heard from previous talks. That sort of regression, you mentioned that schizophrenia is not present in Down syndrome. Schizophrenia is many, many different things and many different symptoms. And some of those involve negative symptoms of schizophrenia, which in fact is those kind of autistic responses. And with some of the advances in our understanding of schizophrenia, those kind of symptoms tend to rely on glutamate. And a reduction in glutamate is thought to perhaps underlie some of those autistic symptoms in schizophrenia. That's what we're seeing in Down syndrome as well, is this absence or impairment in glutamatergic function. So it may be, as a hypothesis, that might be underlying those kinds of symptoms.
Thank you.